Thanks, Joe. It's really, I've been tweaking this talk for about 20 years now, and there's about a 5-year cycle length where everything changes about every 5 years. So those of you who've heard this talk in the last 2 or 3 years, you may say it's nothing different. Hasn't really changed a lot in the last couple of years. I will, let's see, here we go. My field of interest is drug and device development, so I do have lots of disclosures. Most of my interest is in drug device therapy and safety, and so I do work a lot with industry. I actually think, before I start off, I will say one thing. If you do have evaluation forms to fill them out, please fill them out after the lectures. For some reason, my evaluations always go down after the rhythm recognition questions in the afternoon. So, it's just fill them out after the talk. Okay, so I think that the next 2 slides are actually the key slides that you have to do, because even though you see people with heart rhythms every day, you probably don't concentrate on them in a systematic fashion, and that's absolutely what's required. So when you think about arrhythmias, you have to think about a number of diagnostic steps. And the first is to identify and characterize the patient, and you really have to know something about them. What type of heart disease do they have? What does their ECG look like? Do they have a history of arrhythmias? Are they on therapy? What are their current symptoms and what are their disease state? And in fact, rather than agonizing over some ECG, if you know something about the history, you probably have a pretty good differential diagnosis even before you look at the cardiogram. The second thing is never accept suboptimal ECG data. So if you can get a 12-lead ECG, get it. A lot of your patients will have pacemakers and ICDs in the intensive care unit, and those devices provide electrograms and settings that you need to understand to diagnose an arrhythmia. And frequently, it's helpful to get an old ECG, even though sometimes that's not available. Once you've got that, your first step is always to identify and characterize ventricular activity, and you have to be very specific. You want to know what's the cycle length, which is obviously related to the rate. What's the QRS morphology, and is it wide or narrow? Is the QRS regular or irregular? How does this relate to the baseline ECG? And are there typical patterns which give you a direction for a diagnosis, like a bundle branch block or a pre-excitation, Wolff-Parkinson-White syndrome? You then do the same thing for atrial activity, cycle length, rate, morphology, regularity, and then you have to characterize the AV, or more frequently the VA relationship, and figure out how does that affect the diagnosis. And then once you've done that, you usually can diagnose what the rhythm is, or at least narrow it down to 1 or 2 possibilities. When you think about how you're going to treat things, though, you have to understand a little bit about the mechanism responsible. And in general, you can talk about abnormalities of conduction, which are usually reentry, and you can think about abnormalities of automaticity. And if you do that in reentry, where we're talking about conduction, it's usually easier to produce block in some part of the circuit, or at least facilitate block at the elevated rates of the arrhythmia. When you have multiple areas of reentry, you have to normalize the refractory periods and get all the tissue to behave similarly, or you give up, you shock the patient, and you hope you go back to a stable baseline. For automatic rhythms, well, what's causing the automatic rhythms? And in the intensive care unit, it's usually some critical disease. And so for every patient, you have to treat the underlying disease. But you also can inhibit the response of the tissue, or if it's a single area that's causing the problem, we can sometimes localize it and then ablate it with some sort of energy or surgical procedure. You also have to understand that there's differences in cardiac tissues. And grossly, we can think of nodal tissues which have a set of electrophysiologic properties such that they slow conduction at faster heart rates. This leads to Wenke box cycles with dropped beats. You get concealed conduction where impulses affect the tissue, change its properties, but aren't seen on the surface cardiogram. All of these are autonomically sensitive. They usually speed conduction, shorten refractoriness with sympathetic stimulation, the opposite with vagal stimulation, and calcium channels are dependent in the sinus and the AV node. For muscular tissues or accessory pathways, which are a form of muscular tissues, it's different. It's a sodium channel dependent action potential. They still respond to adrenergic stress, But there's no concealed conduction. They don't usually Wenckebach. They either conduct or don't conduct, and so they're sometimes harder to manage. Now, why are arrhythmias bad? You know, arrhythmias ruin your day in the intensive care unit. You can have some disease, you think you're doing it, and all of a sudden you have an arrhythmia come up that sets it back, the disease gets worse, that makes the arrhythmia harder to treat, and you're in this vicious cycle. What's even worse is that many of the therapies we use for arrhythmias will make your disease process worse. Many of them are depressants, or many of them will lower blood pressure. So we really have this vicious cycle. We wish arrhythmias didn't occur, but we often have to be very selective in how we treat them. Now, let's go over the normal conduction system. This is the normal conduction system. It's the sinoatrial node, the AV node, the His bundle, the left bundle branch, and the right bundle. And if the back could hit the step button, because I can't do it. Can someone hit step? Okay. And if we peel back the heart and do it one more time, we can see that the sinus node is here, the AV node is here, we then conduct to the bundle of His, we come down through the right bundles and hit step one more time. Okay. May not be able to do that. So that we have a process of those arrhythmias moving on, and then let's go to the next slide. And you can see in normal sinus rhythm what happens is that the impulse starts in the sinus node. We can measure that if we record from inside the heart as a time from the P wave getting down. We then have the AV node, which has a slight delay. We then conduct rapidly through the His-Purkinje system, and the arborizations of the bundle branches gives us conduction in a normal QRS complex in a normal situation. Now, all of those tissues have different properties. This is just a diagram of the action potentials from various parts of the heart. And notice that the sinus and the AV node don't have a rapid upstroke. These are not sodium channel dependent. The atrial myocyte looks much different than a Purkinje fiber or a ventricular myocyte. And even within the walls of the ventricle, there are different types of properties. And many of the arrhythmias we deal with are when we get imbalance between these different structures within the walls of the ventricle that predispose to fibrillatory arrhythmias. So in the rest of the talks for the next several hours, what we're going to do is we're going to talk about a specific arrhythmia. We're going to talk about the diagnostic criteria on the surface cardiogram, the mechanisms, and the therapy. And I'll give you some examples of the mechanisms and therapy for most of the important arrhythmias. The one you'll deal with most common is sinus tachycardia. And obviously, by definition, it's a normal P wave in QRS. There's usually 1-to-1 AV conduction. In adults, we usually define it as a rate between 100 and 200 beats per minute. In children, you can get sinus tachycardia at much higher rates. The mechanism is enhanced automaticity, and in general, I think that the sinus node is smarter than I am. So it's usually an appropriate response to some stress. Now, sometimes you'll have people who have what we call inappropriate sinus tachycardias. They have wide swings in their rhythms. Many of these are benign and you just ignore them. Other times they can be symptomatic. So if you're trying to treat sinus tachycardia, you want to avoid it if possible. However, there are times where the sinus rate alone causes problems, particularly in the setting of ischemic heart disease, where that will increase the myocardial demand, and in that situation, usually beta blockers are the treatment of choice. We'll now move to other less common but still important arrhythmias that you have to recognize, and the model for reentrant arrhythmias is really paroxysmal supraventricular tachycardia. By definition, this shows an ECG usually between a rate of 100 and 270 in adults. The QRS should be normal, but you can get rate-dependent aberration or bundle branch block at higher rates even in normal individuals and in particularly in people with pre-existing disease in the heart. What's important for diagnosing these is knowing what the AV or VA relationship is, because that often is a clue to what the mechanism of the arrhythmia is. There are three types of PSVT. AV node reentry, where we have slow and fast pathways in the AV node, and we can use either the slow pathway in one direction and the fast pathway in another. This will determine where the P wave is, and I'll give you some examples of this. We can talk about AV reentry, where we have an accessory connection, some sort of muscular connection outside the AV node His-Purkinje system, which joins the atrium and ventricle. That, again, when you have two pathways that are parallel, one can go backwards, one can go forward, and in the classic type of AV reentry, we have a P wave right after the QRS complex. And then we can have reentry or abnormal automaticity actually in the atrial muscle itself. And where that activity is arising will determine the P wave morphology. Since the AV conduction system and the ventricle are no longer part of the arrhythmia, the AV relationship can be variable. So here's an example of AV node reentry. The concept is that you have two pathways, a fast pathway, which is usually anteriorly and superiorly, and a slow pathway, which comes up inferiorly. Normally in sinus rhythm, what happens is you come down the fast pathway, you go down pretty rapidly. The slow pathway impulse hits refractory tissue, you never see it. So the patient's electrocardiogram looks absolutely normal. What happens, though, if you have different electrophysiologic properties in those pathways and that you bring that out by putting in a premature beat? And we've labeled the premature atrial contraction as S2. What happens now is that the impulse blocks in the fast pathway, then comes around the slow pathway, and now sets up a circuit. And you can get a circular pattern of reentry, which determines the mechanism of the arrhythmia. If you look at intracardiac electrograms, which are shown here, and the surface ECG, you can see that we get a delay as we switch from the fast pathway to the slow pathway. We then go back upwards, and we get this repetitive pattern of activity as the reentry circuit goes on. If you look at the surface cardiogram, how is that going to manifest itself? Well, the forward conduction through the His-Purkinje system is about the same as the backwards conduction in the fast pathway of the AV node. So what you have to look for is little nubbins. We call them pseudo-R primes. Usually they're seen either as negative deflections in the inferior leads or as a positive deflection in lead AVR or V1. That tells you that this is likely to be AV node reentry, or at least makes that the most likely diagnosis, and you can then act accordingly. You can also, less commonly, reverse the circuit. And in that case, you have a slow backwards conduction time, and what you'll see is the retrograde P wave will be what we call a long RP, so a long interval between the R wave and the P wave, relatively short as you come back down the fast pathway, and so this is what we call atypical form of AV node reentry. Now, the other common type of paroxysmal supraventricular tachycardia in people with normal hearts is using accessory pathways. And if you think about it, when the heart starts off in development, it's a long tube of cells, and then the cells differentiate and they form the annulus fibrosus, which separates the atrium from the ventricle electrically, except for the AV node in the His-Purkinje system. No big surprise, lots of people have little strands of muscle that are left there, and in some people, those strands of muscle are electrically active and can conduct either forwards and backwards, sometimes only forwards, sometimes only backwards. And those are called accessory pathways. Now, what happens if you have an accessory pathway that can conduct forward? Well, this is a diagram. This is the sinus node. This is the sinus node, the AV node. Normally, we just see conduction this way. But if you have an accessory pathway, remember that's muscle. That doesn't have delayed conduction like the AV node. So what you're going to do is you're going to activate the ventricle faster. You're going to pre-excite the ventricle. But when you get to the ventricle, you're not plugging into the His-Purkinje system. Your conduction in the ventricle is going to be delayed. So you get a slowed up stroke, the so-called delta wave, and then you fuse the rest of the compound. And the relative conduction between the AV node and this accessory pathway is depend on how big that delta wave is going to be and how abnormal your conduction is going to look like. So if we look at a surface cardiogram, the characteristics of somebody with Wolff-Parkinson-White syndrome, who's using their accessory pathway in a forward direction is that they'll have a short PR interval because the AV nodal conduction delay is not there, a slurred upstroke, the delta wave, and then the rest of the QRS is a fusion complex between normal conduction and conduction over that accessory pathway. Now, why is that important? If you have two parallel pathways, most of the time they'll conduct in one direction. But if they block in one direction and you go backwards, what happens is you typically will come down the AV node, go back up the accessory pathway, activate the atrium, activate the AV node, and go around and around until there's something that's done to interrupt that circuit. If you look at that, the difference between this and AV node reentry is in AV node reentry, the turnaround point has to pass through something, the His-Purkinje system, before it gets to the ventricle. In AV reentry with Wolff-Parkinson-White syndrome, you have to pass through the ventricle before you get back to the atrium. You can't get to the accessory pathway until you get through the ventricle. So the P wave is usually in the early ST segment. And I've labeled it here. And in the usual form, like in the other situation, you can reverse this circuit as well. In the usual form, you come down through the normal AV conduction system so that there's no delta wave. There may be a delta wave in sinus rhythm, but there isn't one in tachycardia. Now, that's one problem with accessory pathways. The other problem is if we have rapid atrial arrhythmias, and that can be atrial fibrillation, we no longer have that delay in the AV node. We no longer have concealed conduction slowing the ventricular response. What we have is a piece of muscle. And some ventricular muscle and some accessory pathways have very short refractory periods. And if you have very short refractory periods, you get very rapid rates that can degenerate to ventricular fibrillation. So even though it's rare, people with Wolff-Parkinson-White syndrome can present with cardiac arrest. Atrial fibrillation is a malignant arrhythmia in these people if they have a short refractory period, and that's one of the things that causes us to be very aggressive in trying to eliminate accessory pathways. You should be able to recognize pre-excited atrial arrhythmias. This is an ECG of someone with pre-excited atrial fibrillation, and the characteristics you want to look at are it is an irregular rhythm. The QRS is very bizarre. It's a weird-looking QRS. Frequently, you'll say changes in morphology in the QRS because, remember, you can still come down the AV node, and so you often get variable degrees of fusion between accessory pathway conduction, AV nodal conduction, and because it's atrial fibrillation, you get the irregular rate. Now, how do you treat supraventricular arrhythmias or supraventricular tachycardia? Well, this slide actually tells you everything. We have three types. We have AV node reentry, we have AV reentry using accessory pathway, and we have atrial tachycardias. In acute therapy for reentrant arrhythmias, remember that a single block in the circuit will terminate the arrhythmia. If you have a circuit going around and you block that, even for a beat, you stop the arrhythmia. So for acute therapy, vagal maneuvers, very short-acting drugs on the AV node like adenosine, or longer-acting drugs like verapamil and diltiazem are the therapy of choice. Chronic therapy we'll get into a little bit later or next couple of slides. For atrial arrhythmias, remember the AV node isn't part of the circuit. So even though you may affect the ventricular rate by treatment of the AV node, you may not affect the atrial arrhythmia. So adenosine sometimes will terminate these arrhythmias, but not by its effect on the AV node. Verapamil and diltiazem may give you better rate control, but rarely will terminate an atrial arrhythmia. And so you now have to use a typical classic antiarrhythmic drug, class 1 or class 3, which will terminate the arrhythmia. This is some things I remember. If you're going through the AV node, if you have an AV node-dependent arrhythmia, well, vagal maneuvers may work. Valsalva, gagging, rest, anything that lowers sympathetic tone will facilitate Wenckebach block. One blocked beat will terminate the arrhythmia. In infants, you can use facial immersion in cold water. But in fact, if you get to the point where you have high sympathetic tone, vagal maneuvers are unlikely to be effective. So we tell our patients, if you feel it coming on, don't finish running your marathon and then try to stop it. Go, lie down, rub on your neck, do a Valsalva, cough, vomit, do whatever you want to do, or don't want to do, I guess. And those often, many patients can just break these spells by themselves, and they never get to be a clinical problem. For breaking reentrant arrhythmias through the AV node or using accessory pathways, giving AV nodal blockers, adenosine, verapamil, diltiazem, is very effective. Sometimes in emergency medicine books, you'll see, don't use adenosine in patients with Wolff-Parkinson-White syndrome. Well, you shouldn't if you're conducting over the accessory pathway. You should if you're conducting over the AV node, and that's the distinction that often isn't made in the emergency medicine textbooks. In fact, if you have AV node reentry or AV reentry, and that's the mechanism of your tachycardia, and you use these things appropriately and it doesn't work, you probably didn't have these rhythms. These things are nearly 100% successful, and you just have to trust them. And if not, go back and look at the cardiogram and say, gee, maybe I'm wrong. What else is going on? How do you make the distinction between using adenosine and a calcium channel blocker? Well, most of the time, it doesn't make a difference. There are situations, adenosine you have to get there as a bolus, so if you have a very poor peripheral IV access, that's not any good. Dipyridamol inhibits adenosine metabolism so that it would be a problem. Things like methylxanthines interfere with the adenosine receptor. The transplanted heart is very sensitive to adenosine, so you have to dosage adjust. And adenosine only lasts seconds, so if you break the tachycardia, the patient comes out and then goes back in, you might as well switch to something with a longer duration of action. Calcium channel blockers can cause circulatory collapse in neonates, so you try to avoid them there. If the blood pressure is low and you're squeamish about giving a calcium channel blocker IV, adenosine has a much shorter duration of action. If you're not sure of the diagnosis, sometimes adenosine is helpful. And there are situations, particularly if someone's gotten an IV beta blocker for some reason, that you shouldn't use a calcium channel blocker because there's a higher incidence of sinus arrest or sinus standstill. So for chronic therapy, things are a little different. Again, lots of people have some form of supraventricular tachycardia, and in most of them, it either occurs so rarely or has such mild symptoms, and they can break it, that it's hard to say you're going to benefit them by treating them. If it gets to the point, and my thing is if it interferes with your life or ever causes you to see a doctor, you should fix it. And right now, the standard of care is that almost everybody should have an ablation for the simple forms of supraventricular tachycardia. The success rates and the complication rates with ablating either AV node reentry, accessory pathways, or some atrial tachycardias is very high. Drug therapy is sort of a fallback. There's no drug that effectively targets only what you're interested in. So you have to treat the whole heart. You can't get it in just acutely unless the person is willing to start their own IV. So really, drug therapy is sort of, we use only if ablation is either unsuccessful or for some reason is contraindicated. How does ablation work? The typical thing we use are either heat energy or cold energy. Radiofrequency ablation is the mechanism for heat injury. We heat the surrounding tissue and then it conducts out. The lesion is very small, so it's not arrhythmogenic, and the tissues that you're targeting are very small. So, for example, in AV node reentry, we know that the slow pathway is an inferior structure, so we take a catheter, we put it where the slow pathway is, we block that by heating the tissue, the patient goes back to normal, we don't have to worry about it anymore. For accessory pathways, we find out where the accessory pathway is, usually in the AV groove. This is a right-sided accessory pathway. We make recordings to determine where it is. We heat the tissue. We block the accessory pathway. And as you can see, here's somebody with pre-excitation. This is a left-sided accessory pathway by the ECG pattern. We turn on power. The tissue goes up. You're back to normal. And essentially, that's a lifelong cure. And that's why ablation is really first-line therapy for almost anybody with SVT. Now, atrial tachycardias are a bit more of a problem, and particularly, you usually aren't born with an atrial tachycardia, you usually develop it. By definition, the atrial rate is between 100 and 250 beats per minute. Faster than that, by definition, we call them flutter. There's not all that much difference. The P-wave morphology will depend on the site of origin. You can have 1-to-1, 2-to-1, 3-to-1 variable conduction ratios, and this is often unstable. Because remember, the conduction ratio depends on the AV node. It doesn't depend on the atrial tachycardia. Since you're starting in the atrium, your QRS should be normal, but you can get rate-related bundle branch block. The mechanism is hard to determine. Automaticity, micro reentry, large circuit reentries are all possible, particularly in people who've had surgery on their atrium. You have a scar in the atrium, the scar affects conduction, and so that can cause atrial tachycardias. And in the elderly patients, after cardiac surgically or unfortunately after some of our ablation procedures, we cause scars, we cause tachycardias, we make things worse than they started out with. What about therapy? Well, adenosine response, some of the automatic runs are adenosine sensitive. So sometimes you can break these tachycardias with adenosine, but that doesn't tell you necessarily that it's AV node reentry or AV reentry. These things are really hard to treat with antiarrhythmic drugs. Rate control is often difficult. If you can ablate them, but you frequently can't successfully ablate them or easily ablate them, you try to do it. Atrial tachycardias are a poorly understood, diverse group of arrhythmias that are a real pain in the butt if you have one or if you're trying to treat them. Here's an example of an atrial tachycardia. It's often not very apparent on the cardiogram. You have to look for these very small P waves, and here you can see they're 2-to-1. Down here, you're not even sure where the P waves are. In fact, these things are P waves here, and that is something that gives you rise to an atrial tachycardia. What we do is we'll see people come in the morning, and we'll see somebody who has a heart rate of 122, and people say, oh, it's sinus tach. But then we look, they go to sleep, their heart rate's 122, they walk around, their heart rate's 122, or unfortunately 244, and you just have to look for these stepwise increases in heart rate. And if you have somebody whose heart rate doesn't vary, suspect that it may be an atrial tachycardia. Now, atrial flutter is sort of a specific type of atrial tachycardia. The atrial rate is around 300, but has a range from 250 to 350. And then again, we have different terminology that we use for atrial flutter. For typical atrial flutter, those are the flutter waves, the sawtooth patterns in 2-3 and AVF. But there are other things that fall into this rubric of atrial flutter. There's atypical atrial flutter where you don't see that sawtooth pattern. There's type 2 where you have very rapid but regular atrial activity. Because the rates are very rapid, you usually get some degree of AV block. Classically, it's 2-to-1, but it can be 3-to-1, 4-to-1, variable conduction ratios. Again, since it's an atrial arrhythmia, the QRS should stay narrow, but at faster rates you can get aberration. Now, here the mechanism is very important in terms of designing therapy. Counterclockwise, the typical atrial flutter, the sawtooth pattern, is a counterclockwise macro circuit in the right atrium. And this circuit is defined by set anatomic boundaries, and it's usually what we call cavo-tricuspid isthmus dependent, and I'll show you a diagram of that. Now, in atypical flutter, where you don't get this sawtooth pattern, the circuit's a little harder to define. Sometimes it's just this circuit backwards, but it can be any place else. Importantly now, as atrial fibrillation ablation procedures become more widespread, some of those cause atypical flutter, and they're very difficult to treat, so you have to know about that if somebody has had an atrial fibrillation ablation. Type 2 really is localized activity that's regular, but if you look at the whole heart, you frequently have other areas that are irregularly irregular, and so type 2, you hate to say it, that's also known as flutter fib, but there really is something called that should be called flutter fib. Now, what does atrial flutter look like? Well, this is the classic sawtooth pattern that you see in the surface leads, and here's the circuit. It passes up the atrial septum, around and down the lateral right atrial wall, and passes through this isthmus of tissue between the inferior vena cava and the tricuspid annulus. So this is classic atrial flutter or typical atrial flutter, and everyone should be able to recognize that on the surface cardiogram. Of course, it's a lot easier if you don't have 2-to-1 conduction, because in 2-to-1 conduction, you have to really suspect it. if you see these negative things, because otherwise you might say, well, those are T waves. But you really have to think about it, and when you see a heart rate between 140 and 160 that's dead on regular, always think maybe this is a atrial flutter. How do we treat that? Well, if we're going through that circuit, and you have to go through that circuit, we can draw a line of block with our catheters right through there. We put it on the tricuspid annulus. We pull it back down to the inferior vena cava. We burn the tissue so that it can't conduct. That blocks the tissue, and then we're okay. And the etiologies of atrial flutter are what can cause conduction abnormalities that affect the tricuspid isthmus. Well, atrial stretch, fibrosis, or scarring, any heart disease, frankly. It's often, unfortunately, since these are the same things that cause atrial fibrillation, it's often seen with atrial fibrillation. And one of the very disappointing factors is that frequently if you have people with both atrial flutter and atrial fibrillation and you treat the atrial flutter, they then go on to have atrial fibrillation. This fibrosis and scarring often affects the sinus node, so you may be limited in drug therapy in terms of treating it. Frequently you'll have to use a pacemaker and associated with it. And as I said, we are now creating new atrial flutters with left atrial ablation procedures that are used to treat atrial fibrillation. How do you treat atrial flutter? Well, acutely, it's really hard to control the ventricular rate. And the reason is that you don't get that phenomena of concealed conduction. What you have is concealed conduction means that impulses hit the AV node, reset the refractory period of that tissue, and delay the conduction of the next impulse. In atrial flutter, since you're hitting it at a fairly regular cycle length, one impulse conducts, the other impulse doesn't, and affecting that ratio is fairly difficult. However, some of the treatments we use will change the properties of the AV node or slow down the cycle length. So we do use drugs that affect the AV node, but mostly to prevent one-to-one conduction and making things worse. There are drugs that are effective for atrial flutter. Butylide has its own problems, but is more effective than procanamide. Electrical things like DC shock or rapid pacing are very effective. We will remember, though, that if you're dealing with atrial flutter, you have the same problems with clot formation that you have in atrial fibrillation, so the rules for flutter anticoagulation are the same with atrial fibrillation. Chronically, ablation is very effective if you have a discrete circuit, but late atrial fibrillation is a real long-term problem. Drugs are not particularly effective for atrial flutter. It's difficult to use them, but you often, if you can't ablate the flutter, you do have to use standard antiarrhythmic drugs. Now, a couple of words about multifocal atrial tachycardia. I keep waiting for something new to be reported about multifocal atrial tachycardia. The only thing I can say is I think the incidence or prevalence is decreasing as we get better at managing patients in intensive care units. I now only see a couple of cases a year, but I obviously don't see all of it. Maybe I just don't get called. The ECG is a rate of 110 to 150 beats per minute. The key is that you have discrete P waves that are variable, and there's usually one-to-one AV conduction because it usually occurs in stress states. The mechanism is enhanced automaticity in multiple atrial sites, and the etiologies are anybody who's sick. Theophylline methylxanthines are the classic, catecholamines, but really any critical illness can do it. You also will see elderly patients who have what we call wandering atrial pacemakers. So when they're healthy, they'll have a bunch of P waves coming from various sites, but their heart rate is 70 to 80. Well, if they had a temperature of 39, they're going to have a bunch of P waves coming from multiple sites, but now their heart rate's going to be 130. And so it's really, they have sinus node dysfunction, they have a lot of automaticity in other sites, and it's the critical illness which is doing it rather than a primary arrhythmia. This shows you the example of MAT, what you want to do, discrete P waves, but different morphologies. How do you treat it? Well, if you use pharmacologic or industrial doses of magnesium, you can actually get MAT to go away. This is, if you've ever, I actually tried this a couple of times, and everybody got so sick, I said MAT is not so bad. but you can use it. This is 2 grams in 10 minutes, then 2 grams an hour for 5 hours. MAT will go away. So, it's sort of all bleeding will stop, I guess, eventually is the thing. So again, for MAT, reverse the underlying illnesses. Lots of things have been tried. Magnesium, metoprolol, verapamil, potassium. Amiodarone actually does work, so that you can use IV amiodarone in people with really problematic MAT. There are a few people who have chronic multifocal atrial tachycardia. Every time they walk across the room, their heart rate is 140, and they've got automaticity from various sites. In those people, you occasionally can use AV junctional ablation and pacing. That gives you rate control. If you have good ventricular function to start with, it's not a bad option, but it's not something we do anymore. Non-paroxysmal junctional tachycardia is a very rare rhythm. The rate's between 60 and 150. Again, it's a normal QRS. You can either conduct backwards or block backwards. You can get bundle branch block, but it's really rare. And the ECG pattern it looks like other tachycardias. You have to suspect this if you see it. Again, this is enhanced automaticity in the proximal His region, and you've either suppressed normal pacemakers or you've stimulated this automaticity in a subsidiary pacemaker, or your heart's really sick and this is the only stuff that can beat anymore. So you really have to think about this. This is not a very common rhythm. The other rule I use with diagnosing rhythms, if it takes you more than a sentence to diagnose an arrhythmia, you're probably wrong. So, I'll have somebody say, I think this is a junctional tachycardia with antegrade, left bundle branch block, and intermittent PVCs. No matter what, if it takes you that long to say what's going on, you're probably not correct. So this is, again, what you've done is you've suppressed the normal pacemakers of the heart, and then you get a lower pacemaker which is beating at an abnormal rate. So non-paroxysmal junctional tachycardia. The one time I see this still is you take somebody, this is somebody who had mitral valve surgery, had been in atrial fibrillation for a number of years, went to have mitral valve surgery, got defibrillated after they came off bypass. Their sinus node hadn't been active for years, so it wasn't doing anything. But she was on pressors because of RV dysfunction. The only thing that could beat fast was her junction, so she has a junctional tachycardia. You can actually see there's a retrograde P wave up here, but you can't tell on the surface cardiogram. If I didn't give you a history on this, you can't make the diagnosis of non-paroxysmal junctional tachycardia. Now we get into atrial fibrillation, the worst rhythm that you ever want to deal with. Not really, but if you have it, you think that. There are lots of mechanisms for atrial fibrillation. You can get multiple simultaneous reentry circuits. You can get a rapid single circuit which stresses the conduction and you sort of get irregular conduction. You can get focal sources. Often they're situated in the pulmonary veins that just fire very rapidly and put you into atrial fibrillation. This is what atrial fibrillation looks like. This would be a source from a pulmonary vein coming here. This is the left atrium. You're firing away at a very rapid rate. You're depolarizing the atrium. The AV node is your friend here. It's blocking some of the beats so that your ventricular rates are not over 400 like they are in the atrium. And so the characteristics are you get an irregular QRS complex. You get fibrillatory activity or this undulating activity in the atrium without discrete P waves, and the QRS complex should be narrow, but again, you can get rate-related bundle branch block. Now, dealing with atrial fibrillation in the literature is pretty complicated because there are different forms of atrial fibrillation and there are different clinical scenarios in which atrial fibrillation occurs, and unless you sort those out, it's hard to know what you read someplace about some type of atrial fibrillation applies to your patient. So one of the conventional things is when somebody first presents with atrial fibrillation, we really don't know whether it's going to have a pattern where it's usually self-terminating or whether you have to do something to self-terminate it, or if you have somebody who's in atrial fibrillation 100% of the time and you gave up trying to get him out of it, in that case you call it permanent. And if you look at the effectiveness of interventions in atrial fibrillation in the literature, you have to know what type of group they're dealing with. You also have to know where the atrial fibrillation is occurring, because there's some spectrum of correlation between the amount of heart disease you have and the mechanism. If you've got a left atrium that's been stretched for years by heart failure, has few beating atrial myocytes, and you've got a lot of scarring, well, then you usually have permanent or persistent atrial fibrillation, and it's due to reentry that's just chronic in the atrium. If you're a 32-year-old swimmer or runner who gets atrial fibrillation when they're running marathons and then it goes away, and your heart's otherwise normal and your atrial size is normal and there's very little scar there, well, you usually have focal sites that are driving the atrial fibrillation, and the atrial fibrillation stops on their own. The problem is most people are in atrial fibrillation are sort of in the middle. They have heart disease, frequently hypertension. They have some degree of atrial scarring and maybe a little bit of left atrial enlargement. And they can have combinations of these things, and it's hard to know how to manage them. So the etiology of atrial fibrillation is diffuse. Atrial stretch, fibrosis, and scarring. Thyroid disease, particularly even remote thyroid disease, seems to predispose you to atrial fibrillation for life. Vagal influences, the people who get nausea and vomiting is a frequent precipitant of atrial fibrillation. And really any critical illness. So it's one of the few things where high vagal tone and high sympathetic tone both predispose you to atrial fibrillation. Often seen with atrial flutter, and because atrial fibrosis, scarring, and stretch occur in the atrium and can affect the sinus node, you often get sinus node dysfunction and Brady-Tachy syndromes. Now, acute management of atrial fibrillation is really a problem, particularly in the intensive care unit. Usually the first step is to get your ventricular rate under control. That's 90% of the battle in most people. When somebody presents with a first episode, if you can get their rates under control and remove the driver, spontaneous conversion is common. You can help it along in healthy people with drugs like propafenone or flecainide, with either, if you're in Europe, IV loads, or in the States with oral loads. Intravenous drugs, abutolide is more effective than procainamide, but neither of these are wonder drugs, and we will talk a little bit about anticoagulation. Chronically, there are many people who have either recurrent self-terminating episodes of atrial fibrillation or non-self-terminating episodes of atrial fibrillation. And there we have to talk about, is it better to just rate control them, or should we try to keep them in sinus rhythm? There are lots of ablation procedures for atrial fibrillation. I can't talk about them today, but certainly for the appropriate patient, ablation is a good option. When you first see atrial fibrillation, what's the minimum initial workup? Well, you got to know something about the patient. You want to know what their heart's like and what's their history. You want to confirm it with a 12-lead electrocardiogram. The chest X-ray is really looking for other things. It's not useful itself most of the time for atrial fibrillation per se. The echocardiogram is, because valve disease, particularly at faster heart rates, valve disease can be important, can be hidden. Left atrial enlargement can be hidden. And you also want to see, is atrial fibrillation affecting ventricular function? Because we know that persistently rapid rates affect ventricular function and in and of themselves can cause a cardiomyopathy. And certainly thyroid functions, you never want to miss the patient who's hyperthyroid and their first manifestation is atrial fibrillation. For treatment options of atrial fibrillation, you have to think about, how do I control ventricular rate? Should I and how do I maintain sinus rhythm? Because I have both pharmacologic options and non-pharmacologic options. And how do I keep strokes or emboli from occurring? When do I use warfarin? When do I use aspirin? When do I use other things? Let's talk about anticoagulation first. This is the left atrial appendage on a transesophageal echocardiogram. This is a bad thing to have in your left atrial appendage. This is a large thrombus. If this breaks loose, and this can break loose in atrial fibrillation, and it will cause a stroke, and strokes in people with atrial fibrillation are worse than the average stroke. It's been estimated that about 15% of the strokes in the United States are due to atrial fibrillation in some way, so it's really both an important individual patient concern and a public health issue. So we have guidelines for anticoagulation. Most people say that if the episode lasts less than 48 hours, a stroke hasn't had time to occur or to form. And so if you see somebody and you're sure the atrial fibrillation is of recent onset, you can cardiovert them without prior anticoagulation. But frequently you're not sure of that, and frequently this episode may have lasted 6 hours, but there may have been 12 other episodes over the last 3 days, so you do have to be careful. If the episodes lasted longer than 48 hours, unless the patient is an extremis, you should not cardiovert them acutely unless you know that there's no clot in the left atrium. So you either have to put them on anticoagulation for 3 weeks or get a negative transesophageal echo that actually interrogates the left atrial appendage, shows that there's no clot there, and only then can you go ahead. In chronic patients who either have paroxysmal, persistent, or permanent atrial fibrillation, then you're talking about balancing the risks of bleeding versus the risk of stroke. And the guidelines say if you're young and have no risk factors, and we'll talk about what those are, you can either use aspirin, which is a very weakly effective drug in atrial fibrillation, or nothing. Older patients, the standard is to still use warfarin. However, you have to remember that about a third of patients have pretty hard contraindications to warfarin, and so there are a lot of people with atrial fibrillation who just can't be anticoagulated. There are newer drugs. There's a whole family of new compounds that affect either direct thrombin inhibitors or factor Xa inhibitors that are coming. One of them, dabigatran, may be released, or at least it's going to FDA panel later this year. That will make anticoagulation simpler, but really won't eliminate all of the problems. How do we assess stroke risk? There are a number of different scoring systems. All of them are relatively weak. The one that everybody could remember is CHADS-2, where you get 1 point for congestive heart failure, 1 point for hypertension, 1 point for an age over 75, 1 point if you have diabetes, and if you had a prior stroke or TIA. You add up these numbers, and if you have a score of 0, there's little benefit from having anticoagulation. For 1, the recommendation is, well, most people should be anticoagulated, but you have to look at the bleeding risk. So you have an option. It's either aspirin or warfarin. But if you're above a CHADS score of 2, you definitely have a high stroke risk. And in most people, the benefit is there's going to be benefit to using chronic warfarin anticoagulation. Rate control. How do we rate control people in atrial fibrillation? I think there are 4 options we have. The best is probably beta blockers. And you can use intravenous beta blockers, any type, or oral beta blockers, any type. The problem is we're often limited with hypotension, and some people you just don't get effective rate control no matter how high you go with the dose of beta blockers. Calcium channel blockers, either diltiazem or verapamil, and you can, even though it's not usually thought of as an IV drug, you can use verapamil IV as well. The limitation here is that these drugs make people with severe left ventricular dysfunction worse. So you have to avoid calcium channel blockers with severe left ventricular dysfunction. You can use it if ventricular function is okay, and they are quite effective. Then you're usually limited by blood pressure effects. Digoxin, the problem is, it does have some effect to slow rates, but it doesn't do it very well in times of sympathetic stress. So in the intensive care unit, it's background therapy, rarely can be used alone. And sometimes we just use amiodarone, even though we're not trying to cardiovert the patient. We're using amiodarone because of its effect as both a weak calcium channel blocker, a non-competitive beta blocker, and some other non-specific effects. It does lower heart rate, and you can use it in patients with atrial fibrillation. Non-pharmacologic, we sometimes run out of options. AV junctional ablation with a pacemaker, particularly using in patients with heart failure, cardiac resynchronization can be very effective. But since this is an irreversible option and makes the patient truly pacemaker dependent, again, it's usually our last option. What's important to know is, what's my target? We used to say that we wanted the heart rate in atrial fibrillation to be the same as in sinus rhythm. we don't really have to go that low. We used to try to keep people less than 80 beats per minute. A recent study by Van Gelder et al., the Rate 2 study, shows there's really not much difference. If your resting heart rate is less than 100, you're probably okay. You don't want people, though, to have very excessive heart rates with moderate exercise, so you do want to look at heart rates during exercise, and you probably shouldn't have very abnormal heart rates at peak exercise. Those would be your goal in the outpatient. In the intensive care unit, you usually can't get people below 100 if they're still sick. So what you want to do is, what's the rate at which most people will start to have deterioration from heart rate alone? And that's going to be around 120 beats per minute. So in the post-op intensive care unit, in the other intensive care units, if you get a rate below 120, you can start to breathe a little easier. You can start working on the underlying problem. And then finally, in order to get these rates, you are going to have pauses that look funny. So all the time I'll come in and somebody will show me, oh my God, there's this 3-second pause. Well, they usually start with 2 seconds, and I say, oh good, that's just where you want to be. Then they show me 3 seconds, and I say, yeah, that's even better. Then they show me about 6 seconds. And then even I start to get nervous about 6 or 8 seconds. But you'd really want to do, if they aren't symptomatic, you really want to be sort of reluctant to intervene in people. Obviously, you shouldn't take people down to sustained heart rates in the 30s, but many people will maintain heart rates in the 40s when they're asleep without any symptoms, and you try to avoid intervening if you can. Does it make a difference whether or not you rhythm control people or rate control people? There are now 7 rate control versus rhythm control studies. All of them have shown that there's no benefit in mildly symptomatic patients, whether you use rhythm control or rate control. This is the AFFIRM trial. In fact, in the AFFIRM, which was a 4,000-patient study, there was slightly higher mortality associated with trying to maintain sinus rhythm. Complex reasons for that, but in any event, you get your option. If you can control symptoms, you're okay. How do we maintain sinus rhythm? Well, there are a number of drugs, and it's all dependent on how does the patient tolerate it. So if you have no or minimal heart disease, you can use drugs like flecainide, propafenone, or sotalol. If you have hypertension, these drugs are bad. So if you have LVH, your only option is amiodarone. If you have no LVH, you can use those drugs. If you have heart disease, well, then we have difetilide and sotalol, and then amiodarone. And if you have heart failure, amiodarone and difetilide are the only drugs that are thought to be safe. And you know amiodarone has lots of other side effects, but no one sort of argues that amiodarone is the most effective antiarrhythmic drug. It's not labeled for it, but everybody uses it. It's in fact the most commonly used antiarrhythmic drug in the country. This is just one of many studies showing that amiodarone beats out other compounds like propafenone or sotalol. There is a new kid on the block called dronedarone. Some of us joke that it's amiodarone light. It's a deiodinated congener of amiodarone. There's a large study called Athena where they did show that there was a benefit, but they weren't looking actually at atrial fibrillation. What they looked at is death and rehospitalization for cardiovascular purposes. This is the New England Journal paper, there was a benefit shown with dronedarone. There was also another study that showed dronedarone increased mortality in patients with recently decompensated heart failure. So there's a black box warning about using dronedarone with heart failure, but it is available. It's extraordinarily expensive, so you have to be careful about that, but it does offer a newer option that was not available a couple of years ago. In general, when I talk with people of atrial fibrillation, I say, you are going to have another episode of atrial fibrillation, unless there's something really discrete and reversible. Getting totally rid of your symptoms is, I say, difficult. It's probably impossible. Improvements in the frequency, duration, and severity are the most realistic goals of therapy, and because of that, we shouldn't kill people trying to eliminate atrial fibrillation. Catheter ablation, this is a diagram of the left atrium, and what we've done is we've isolated the pulmonary veins, which are frequent sources, and then we draw these what are called lines down to the mitral isthmus and connecting the pulmonary veins. We try to break up the circuits It works very well in some patients, works poorly in others, and makes others worse. You have to be aware of it, but it's certainly not a panacea for most patients. And finally, when do you admit a patient with atrial fibrillation? Well, look at do they have another disease requiring admission? Atrial fibrillation itself does not require an admission. If you can't control the rate, so the patient's still asymptomatic and has a fast heart rate. Persistent symptoms, get them in. A lot of the drugs we use have to be loaded in hospitals, so you want to do that. And then if you're planning an early cardioversion, then you want to get the person anticoagulated. You may want to get a TEE depending upon the duration, and that often is much easier to do on an inpatient basis. So final points about atrial fibrillation. It affects up to 10% of the elderly population. You really want to look at symptom relief and stroke prevention. You have to choose between rate control and rhythm control. Both are acceptable if you can control symptoms and prevent stroke. And you always have to think about anticoagulation. There are really some pretty good practice guidelines for arrhythmias, for supraventricular arrhythmias, atrial fibrillation, and ventricular arrhythmias. Unfortunately, they're a little bit dated now, so that there are revisions both for these and these that are in the works. This textbook has a relatively recent section on cardiac arrhythmias, and there's a good section in Brownwall's Cardiovascular Therapeutics that if you want to look at it. Thanks very much.